Hello everyone and welcome to the fifth session of Jafran e-seminar series. This seminar will discuss the hemoperfusion therapy in COVID, principle and practical experience. In this webinar, we will have two lectures. The first will be about the combining hemoperfusion with ECMO CRT experience from Italy. It will be presented by Dr. Matteo Brivio. The second lecture will be about the role of hemoperfusion HA330 in critically ill COVID-19 patients. It will be presented by Dr. Venugopal from India. So let me introduce the first topic. It will be about the combining hemoperfusion with ECMO CRT experience from Italy. It will be presented by Dr. Matteo Brivio from Italy. Dr. Matteo, he's graduated in medicine at Milan University in 2004 and completed his residency in anesthesia and intensive care medicine in 2008 at Parma University, attending during his training the UPMC in Pittsburgh, USA, and the University of Vienna at AKH Hospital, Vienna, Australia. He works as a consultant in a 16-bed cardiac and general ICU in Papa Giovanni 23rd Hospital in Bergamo, Italy, which is tertiary 1,000 beds hospital serving 1 million people, county and Lombardy in northern Italy. Papa Giovanni 23 Hospital is one of the teaching hospitals of the Milan University, hosting the School of Medicine and Surgery and an English and master degree program in partnership with the University of Surrey, UK. The main activities of the ICU center at he works ranges from cardiac and general surgery patients care to acute medical cardiac failure and acute respiratory failure management, providing all kinds of extracorporeal multi-organ support, including both veno-arterial and veno-venous ECMO. He is a member of the Italian Anesthesia and Intensive Care Society. He participates in cardiovascular and renal research activities in his department. Dr. Matteo, is your time. Please share your presentation, please.
Okay, so good evening, everybody, and thank you for inviting me to such an interesting event. In this presentation, I will talk about the hemoperfusion therapy in COVID patients, and I will talk about principle and practical experience that we want to share from my hospital in Bergamo. Briefly, in the next 20 minutes, I will analyze the role of cytokine storm in COVID-19 pathophysiology, and then the role of cytokines in spread in multiple organ dysfunction. I will take in consideration the use of extracorporeal sorbent therapies to trying to counteract the effects of cytokine storm. And then I will end up my presentation with sharing a clinical case report in which we use multiple organ support, combining ECMO with CRRT and sorbent cartridges. So let's start with COVID pathophysiology. Just to say that we can find three infection phases. The first one, which is mainly interested by viral invasion and presents mild symptoms. The second one, in which we have a pulmonary phase with normally only one organ involved, and the main symptom is respiratory failure. And the third one, hyperinflammation phase, in which we have a multiple organ derangement due to the host inflammatory response. The second and the third phases are of direct interest of the intensive care physician, mainly because of the multiple organ failure which we have to face. But how does it happens? The viral spread in lungs generate a response from the host, which results in pro-inflammatory cytokine spread. In a patient who develop a severe pattern, which you can see on the cartoon on the left side, there is a high level of pro-inflammatory cytokines that spreads in lung alveoli, leading to alveoli damage and pulmonary leakage and edema. There is also a vessel side with a microvascular thrombosis, which happens in the capillary vessels. In patients who present mild pattern, the cytokine spread is quite low, and so is the microthrombosis, leading to a mild clinical symptoms. It's important, very important to point out that not every patient, fortunately, exhibits a pathological response. The majority exhibits a physiological response to the infection, but there is a small fraction of patients who suffer from a pathological activation of immune system. And this thing leads to two main phenomena. The first one is the hypercoagulability that leads to macrothrombosis, which is either venous and arterial, leading to thromboembolic events. And the second one is the endotheliopathy, which leads to microthrombosis, which is responsible for multi-organ failure. So we studied from these statements in Bergamo, in my institution. We try to understand better this pathophysiology, and we started being a cardiac surgical ICU. Started from the heart. We studied 40 hours coming from patient who died from bilateral pneumonia due to COVID-19, and what we found is that there was a high incidence of microthrombi in a patient who presented an acute cardiac syndrome. So we can conclude that the most common pathological cause of myocyte necrosis in COVID-19 patient was microthrombosis, which is completely different from we can say normal patient, in which we have an epicardial macrothrombosis causing acute coronary syndrome. The second thing we tried to analyze was whether myocarditis was a cause of myocardial injury in COVID-19 patient. And what we found is that myocarditis is uncommon in autopsy in this population. So the myocarditis-like syndrome that we face in some of our patients must be due to high circulating levels of cytokines, the gains. So the cytokine storm was probably responsible for microvascular and microvascular thrombi that would eventually lead to vascular occlusion and cells death. We also analyzed renal involvement in our patients. We studied 130 patients, 130 ICU patients, intubated patient with a severe bilateral interstitial pneumonia. And what we found was that there was a high incidence of patient developing AKA, 57%, and among them, the incidence of stage 3 AKAs was extremely high, 31%. Our data confirms that acute kidney injury represents an independent risk factor for mortality at 28 days for our patient. And also another important statement is that both higher PEEP levels and PVC levels are significantly associated with AKA, suggesting us that the hemodynamic impact of high intrathoracic pressures might be involved in this pathogenesis. We can argue that probably the sicker the patient were, the more we had to ventilate them, the more we had to administer fluids, and the more we probably determined renal damage. The mechanism of renal damage is probably multifactorial. We know that ACE2 receptor for coronavirus is located on the surface of, also on the surface of the kidney tubular cells, and their infection may worsen the inflammatory response and the incidence and the duration of AKA episodes. These can also lead to cytokine overproduction, and particularly in upregulation of IL-6, which we know is associated with lung damage. In particular, it can determine higher alveolar and capillary permeability and pulmonary damage. This direct mechanism of IL-6 injury must be further explored, but also it can cause a worsen in renal function, generating renal medullary hypoxia, thus generating a vicious loop, which is very difficult to interrupt. We can see as our kidneys, lungs, and heart are strictly associated in this syndrome in determining a multi-organ involvement, which is very difficult to handle. What can we do? So to trying to handle, to manage such a complex and severe syndrome? Maybe extracorporeal blood purification and organ support could be a good idea, because it can lead us to a decrease of the peak of cytokines concentration and to a modification in the cytokines ratio from tissue to blood. But we have to point out that cytokines levels are not homogeneous among patients, so we have to be very precise in trying to dosing cytokines level in our patient whenever it's possible. And so what are the indication for initiating extracorporeal blood purification therapy? They are mainly four. The first one is the presence of high circulating cytokines levels, as we said. The second is the presence of high SOFA score. The third one, the hemodynamic instability, requiring vasopressor to maintain adequate perfusion pressure. And the last one is the presence of disorders of coagulation. I have to point out that sometimes those four phenomena are all present in our patients. So again, the more severe is the degree of the illness, the more all those problems are present in our patients. And once we decided to start with such a therapy, how can we carry it on? I think the most important statement, the most important thing to point out is that the adsorptive capacity of our cartridges is usually exhausted after 4-6 hours of usage. So and this capacity decreases in a quite steep fashion. So I think we have to point out that the treatment duration must be 4 to 6 hours. Normally, we do perform 3 or 4 treatments for each patient. Another thing, another very important thing is that we have to maintain blood flow above 120 milliliters per minute in order to avoid the coagulation in the filter. And as we said before, we should change daily our filters in order to maintain an high absorptive capacity. Again, it's important for me to point out that we have to consider this multi-organ failure as because failing organs have in common the blood perfusion the tissues, and so circulating blood becomes our target for our specific treatments. I would like now to end up my presentation presenting you and sharing with you a clinical case report which happened in my institution, in which we used the Jaffron HA380, a natural macropose adsorbent, which has the capacity of a huge active surface around 60 square meters, and could be used in hemoperfusion alone or in couple with CRRT. In the images below, you can see its structures and the enormous active surface due to this structure. It has been used in septic shock patients. In this paper, for example, they use it in coupling with CVVH in a small group of patients in which there was the need for high dosage vasopressor and dysfunction of 2 or more organs, and the presence of suspected presence of gram-negative infection. They used the treatment for 3 consecutive days, and it was used for the first 2 hours. Then the treatment was continued with CVVH alone. What they found was that there was a significant decrease in vasopressor and anotropic drug requirements. As you can see, the vasopressor needs decreased in a very significant way, and their value to maintain mean arterial pressure were significantly decreasing after 24 hours. This kind of absorptive therapy has been used also in COVID-19 patients. And what this group found in this paper was that after 1 week of therapy, the Apache and SOFA score were significantly decreased. And also there was a significantly improvement in gas exchanges in those patients in terms of PO2 and also of PO2-VO2 ratio, leading to a significantly improvement in patient conditions. Okay, so let's go and they also the levels of 34 cytokines, and what they found was that all those levels were significantly decreased after ALS treatment. So let's go to the clinical case. The patient was a male, 48 years old, a medical doctor, a colleague of us, which had a contact with a patient and a COVID swab, and had a positive COVID swab. After 2 days, he needed to be referred to our pulmonology ICU because of high degree respiratory distress. He was put on CPAP and started his ventilatory support. We were called after 12 days because of progression of his respiratory distress. He was support with non-invasive ventilation with a higher level possible support in terms of pressures and also of oxygen delivery. But his gas exchange was very compromised with a PF ratio of 70. So we decided to refer the patient, to intubate the patient and refer him to our ICU. On the picture on the right side of the screen, you can see the severe degree of his bilateral COVID pneumonia, and also the presence of pneumomediastinum. We decided to take him to our ICU and to pronate him, trying to improve his gas exchange. We perform in total 3 pronation cycles without significant improvement in gas exchange, as you can see. On day 17, also we had 2 main complications. The first one was the presence of a significant subcutaneous emphysema, as you can see on the CT scan. And the second one, and most important one, was an hemodynamic instability due to evidence of duodenal bleeding, which needed to be treated by a GDS and positioned, and 2 clips were positioned achieving the control of bleeding. We have to transfuse the patient. We have to fill the patient, and starting with an inotropic support with adrenaline. And obviously, we stopped the administration of heparin. So given the worst pulmonary condition, we didn't could start with the veno-venous ECMO because of bleeding. So we thought about another strategy, and considering the hemodynamic instability, the severe acute respiratory failure, the positive fluid balances that we had to achieve, to achieve a good clinical stability, and the IL-6 dosage, as you can see on the right side, we decided to start with an absorber therapy. We chose, as I said before, the Jaffron cartridge in coupling with CRT treatment on the B. Brown Omni machine. We chose a CVVH technique in pre-dilution with a blood flow starting with 150 milliliters per minute. We chose a low pre-dilution dose because the patient had a normal renal function, and our ultrafiltration of 100 milliliter in order to achieve a good fluid balance control. The treatment dured 6 hours, and we performed only one cycle for first, because we could achieve the next day an hemodynamic stability. We could stop this administration of epinephrine, And since we achieve a good control of bleeding since the last 24 hours, and being a patient and still in a severe ARDS condition, we decided to start it with a veno-venous ECMO support. So we continue the sorbent therapy on the ECMO circuit. So we decided to mount the cartridge directly on the ECMO circuit, and we increase a little bit, as you can see, the blood flow to 200 milliliters per minute. We still perform 6-hour duration cycles, and we did perform a total of 3 other treatments for the 3 following days. On the right side of the screen, you can see where we attached the cartridge on the ECMO circuit. And you can see that the inline was connected to the post-oxygenator line, which has positive pressure, and the outline is connected to the venous line, which has a negative pressure, in order to achieve a good pressure gradient over our filter. After 3 days, what we saw was that the IL-6 levels significantly decreased, as you can see here in this table, and also more important, the pulmonary condition of our patient improved, and his gas exchange improved too. So we decided to stop the absorber and go on with the VV ECMO support. The further clinical course of this patient was still demanding. We could wean him from ECMO only after 2 months, and we could discharge him from the ICU after 4 months. But the most important thing is that he is still alive, and he is back to work since a few months. This is the CT scan we did perform a few days after his ICU discharge. In conclusion, I can say that there is an emerging role for extracorporeal sorbents in CRS syndrome. They are effective, they are safe, and they can achieve a peak in cytokine, a reduction in cytokine peaks. Because sepsis and COVID-19 syndrome are multi-organ illnesses, we need for multi-organ therapies, which can lead to a renal, cardiovascular, respiratory, and liver support. And this kind of support could be sequential or combined, and could follow the patient from the early inflammatory phase to single organ or multiple organ failure. And I finish it, and thank you for the attention.
Thank you, Dr. Matteo, for the great presentation. Now going to the next presentation will be about the role of Hemoperfusion HA330 in critically ill COVID-19 patients. This presentation will be presented by Dr. Venugopal. Dr. Venugopal is the Senior Consultant and Head of the Department of Nephrology in Care Multispecialty Hospital. He's achieved his Doctor of Medicine degree in nephrology in Osmania Medical College, Hyderabad in 2006. He had his MD degree in Andhra Medical College in Visakhapatnam in 2002. And he had several important positions in the past decades in India. He has been dedicated to clinical research and had published several clinical papers. Dr. Venugopal, please share your presentation and start the presentation.
Sorry, Dr. Venugopal, you mute yourself. Please unmute.
Okay, am I audible, Flora?
Yes, we can hear you now.
Yeah, thank you. Good evening. At the outset, I would like to thank Jaffran as well as Delvin for giving me this opportunity to present my views on this critical topic. And I would take this opportunity to thank Dr. Brivio and congratulate him for his excellent presentation on a very difficult topic. As we all know, the entire world is gripped by this pandemic, and every part of the world is facing a big havoc. And we continue to innovate the treatments for COVID-19 as of now. This particular topic is very interesting. Actually, in the past decade or so, I have been doing this extracorporeal therapies, and how this extracorporeal therapy is going to help COVID-19. I still wonder, and I have few points to make and a few the discussion. Video has taken you into the intricacies of and the immune system, but I would like to touch upon the basics of cytokines so that we understand it better, why this hemoperfusion should work well in these settings. As we know that the extracorporeal therapies or the modalities of dialysis are worked to remove the solutes. The basic difference between the solutes that we remove in dialysis and the solutes that we remove in the extracorporeal purification systems is molecular weight. So if you take the molecular weight of most of the solutes in uremic patients in CKD, the molecular weight will range from somewhere between 5 and at the most 30 kilodaltons, whereas the cytokines have got a higher molecular weight of around 70 kilodaltons. So we need to have a membrane which will absorb or filter a larger molecular weight substance. So that's the reason why we got these adsorbents or the sorbents have come into the market. We all know the cytokines are the ones that are producing the major havoc. And I would like to mention two important things, that PAMs and DAMs are the most important proteins that stimulate this entire immune system and produces a wide array of cytokines. So you all know that we have got the immune system is mainly based on two things. One is innate immune system and the other is specific immune system. So in COVID-19 also, the first response of the body is to handle the virus with an innate immune system. If this innate immune system fails, the entire pathogen is presented to the specific immune system. So I would like to touch upon that the innate immune system, the key cell in innate immune system is macrophage. So if the pathogen comes in contact with the macrophage, it always tries to engulf it and phagocytose it. So with the help of toll-like receptors that are present on the macrophages, and these toll-like receptors will interact with the PAMPs. The PAMPs are the proteins that are produced by the pathogens, and the PAMPs will interact with the toll-like receptors in the macrophage, and then the entire process of phagocytosis takes place. If the volume of pathogen is so huge and the macrophages cannot handle this, then the specific immune system will take over. So this particular specific immune system is mainly based on T cells and B cells. So we all know that CD4 helper T cells and the cytotoxic T cells are the ones that are responsible for producing cytokines, and the B cells are responsible for producing antibodies. So once the pathogen is presented and it exceeds the innate ability of the immune system to handle it, then the specific immune system will take over, and then the entire APC activation along with the co-stimuli, and then the production of T cells will take place. We have a wide interplay of cytokines. We have pro-inflammatory cytokines and anti-inflammatory cytokines. So whenever the inflammation takes place, the IL-1 is produced, IL-6 is produced, IL-12 is produced, 10 is produced, 8 is produced, and TNF-alpha is produced. So these particular cytokines that I mentioned were clinically important. If an IL-1 is produced in excess, it goes straight into the brain and starts producing fever, lethargy, reduced appetite. See, all these things are just to conserve the energy by the individual to direct his immune system towards the pathogen. So lethargy, reduced appetite, all those are to conserve the energy to fight the organ, to fight the pathogen. So if we go to the IL-6, the IL-6 will stimulate the liver, and it produces what are called as opsonins. So one of the best examples for opsonins is C-reactive protein. So we started measuring CRP, and then we started measuring IL-6 as what you call it as a markers of inflammation. So the CRP is produced in massive quantities from the liver on the stimulation of IL-6, and then we started measuring this. And the third inflammatory marker that we started measuring is D-dimers. It is a surrogate marker. If the D-dimer is increasing, that means the body has already gone into a mechanism of clotting. So the D-dimer and FDP are the two products, are the byproducts of clot lysis. So a clot has formed and the clot has lysed. So then you're bound to get increased D-dimers and then the FDP levels. So we have come across a long way, and we started measuring only 3 inflammatory markers, that is IL-6, C-reactive protein, and D-dimers. So the IL-6 is produced in enormous quantities by the lymphocytes, by the neutrophils, by the macrophages, and also the precursor macrophages, monocytes. And this and then the CRP is produced by the liver on stimulation by IL-6, and then the D-dimer as a marker of clot lysis. So a clot has formed and the clot has lysed, and it is producing a lot of D-dimer and FDP. So if you are in a confusion whether the D-dimer that you are looking at is in unison with your clinical picture, then you always try to estimate FDP. Both these things should go hand in hand. So as Dr. Brivio mentioned, the mechanism of organ failure has been clearly demarcated in this picture, that once the pathogen enters into the body, and then the pro-inflammatory cytokines will take a surge. And then the pro-inflammatory cytokine surge is so huge that the anti-inflammatory cytokines is not able to handle this, and it produces what is called as an endothelial damage. So the center of organ failure is endothelial damage. If endothelial damage starts occurring, then the clot formation automatically gets activated. So the microthrombi forms, as Dr. Brivio already mentioned, that multiple microthrombi are formed in different organs, and then slowly the organs start failing. So how to counter this cytokine storm and organ support, and how to give this organ support. So this already I mentioned that we have got two types of immune systems, innate as well as adaptive immune systems. And this is the list of cells that are important in innate as well as adaptive immune systems. So the macrophage, neutrophils, dendritic cells, so which are very important, that inflammation is somewhere, and this dendritic cell will take up the pathogen, and it will send a signal to the lymph node or the malt tissues, and then the entire immune system gets activated. So the other cells that are implicated in the pathogenesis are mast cells, basophils, natural killer cells, which are very important cells in innate immune system. So as I mentioned, that the specific or adaptive immune system mainly boils down to T and B cells by the production of antibodies and in the cytokines. So the complex array of cytokines will herald the entire system of inflammation and then produce multi-organ failure by endothelial damage. So the center of multi-organ failure is endothelial damage. So by the time you see a cytokine storm, that means increased levels of these markers, what I mentioned, that IL-6, IL-1, TNF alpha, IL-8, 10, and 12, and then the C-reactive protein and D-dimers, that means your organ started failing already. So that is the reason why we are not getting the results that we anticipate. The most important point of doing one of the heme adsorption or cytokine handling with an antibody is the timing, when to intervene with these therapies. So this particular balance, if it is tilted towards the pro-inflammatory state, we end up having multi-organ failure. So there are wide anti-inflammatory molecules that are available in the body, but the pathogen is surpassing it, and then the large number of chemokines are produced, which is surpassing the capacity of anti-inflammatory state, and we end up in multi-organ failure. So how to prevent this organ failure and reduce the mortality? All these mentioned, the topic of interest today is heme adsorption, and then the heme adsorption, the other mechanisms by which we deal the cytokines are only along with the standard of care. So the standard of care has to be maintained, and then these therapies should be an add-on to the standard of care. So the treatment options that we have are pro-inflammatory cytokine blockers. So there are a lot of government regulations to use these medicines in India. So this siltuximab is not been approved by the ICMR, so we are not able to use this. So IL-6 monoclonal receptor antibody like tocilizumab is an effective pro-inflammatory cytokine blocker. But having said this, tocilizumab is a selective cytokine blocker. So if we block the IL-6 pathway, it is not going to be sufficient in our case, where the wide array of cytokines are getting stimulated. So the therapy boils down to cytokine removal. So as I searched the literature, there are very interesting facts about the cytokine removal. So this particular practice of doing CPFA is being done for so many years now. The CPFA is a very effective way of cytokine removal. I think my learned colleague Dr. Brivio will surely agree that CPFA is a very good way of removing cytokines. But again, not with without any complications. So the other thing is CVV-HDF and CVVH, as he already mentioned, and high volume hemofiltration. The problem with these devices is, again, what I told in the beginning of my talk, that the main problem is molecular weight of these substances. So in these things like CPFA, CVVHD, HVHF, we use a membrane which has got a medium permeability, and then the molecular weight of the substances that are removed during these therapies depends on a lot of factors, including blood flows, the convective clearances, and then the diffusive clearances. So the toremixin, I just mentioned this to complete the talk, that toremixin is also being used for some of the cytokine removal, but Abdomic study have proven that there is no efficacy benefit, and this has been stopped because of the increased mortality. And then the risk of cartridge clotting and acute blood loss is always there when you mention about the extracorporeal therapies. So to continue the adsorption hemofilters, the PMMA membranes have come, which have very promising results when used in conjunction with hemodiafiltrations. So hence beneficial to use these type of membranes in CKD sepsis. The problem with PMMA membranes is the high propensity to clot. So in India, most of the centers will not practice the citrate anticoagulation during extracorporeal therapies because of the cost involved in it. So we would usually do with a bolus heparin and a saline flush and avoid a citrate. But in certain situations, we tend to resort to citrate anticoagulation, especially in patients with the COVID-19 where the propensity to clot is very high. We would advise to go for citrate anticoagulation. And the other membrane is AN69 ST hemofiltration membranes. The ST filters are little advanced compared to AN69 membranes. And then the efficacy is superior to PMMA membranes, which I've mentioned. And the coating on this AN69. So that is the improvement of regular AN69 with AN69 ST, that is PEI coating, which enables endotoxin removals. So if you are using an AN69 ST membrane, then it enables endotoxin removal as well as cytokine removal. So it's a dual purpose. And then it is very advantageous if you start using this AN69 ST as an extracorporeal therapy filter. So not the least, that is Oxiris, which is a modified AN69 ST membrane to prevent clotting. So this is effective in reducing both cytokines as well as endotoxins, and then the clot formation is also very less. So coming to the Cytosol, which has been used prevalent widely in India, it precisely hits the cytokine sweet spot. So like our HA330 filter. So these two filters, the Cytosol and HA330, weigh each other in terms of hitting the cytokine sweet spot. So what do you mean by this cytokine sweet spot? This particular membrane like Cytosol as well as the HA330 have got the propensity to remove the proteins which have got the molecular weight somewhere between 40 and 60 kilodaltons. So all our cytokines fit into this particular molecular weight group. So that's why I mentioned that this as cytokine sweet spot. So the Cytosol as well as HA330 will precisely hit this particular spot, so the removal would be great. And Cytosol has got a wide range of indications, including our HA330, like acute pancreatitis, burns. These days we are using for acute liver failure, and standalone therapy or in conjunction with CRRT. So this is the beauty of using Cytosol or HA330. You can use these filters either alone or in conjunction with CRRT, depending on the need. So coming to our topic of discussion, like HA330 filter, it has got a large surface area. So this scores a bit high than Cytosol in mentioning that the surface area, as Dr. Brivio already mentioned, that it has got up to 60,000 square meters surface area. And the pore size distribution is also wide. So the removal of cytokines is always dependent on the pore size and then the distribution of these pores. So you have got a wide resin pore size distribution. Of course, even the Cytosol is a resin-based filter. And as I mentioned, that it also hits the cytokine sweet spot. So in way back in 2010 and 2013, these two beautiful papers published by Shal and Hyung. This is an RCT. He used this filter for a septic shock patients and beneficial in terms of 2-3 things. That is reducing the mortality, reducing the length of ICU stay, and reduction in the supports. So this particular filter has fared very well in terms of ICU mortality, in terms of length of ICU stay, and in terms of reduction in the supports. So this is the hemoperfusion principle. Dr. Brivio mentioned this. Hemoperfusion is a blood purification therapy based on adsorption technology. So as this is based on adsorption technology, this cannot be used for a prolonged period of time. The cartridge gets settled with these solutes, and then it gets saturated. So or a period of time. So there is a wide debate of how many hours that we use this particular thing. In my experience, more than 3 hours, 3 hours of 2.5 to 3 hours of hemoperfusion is not going to be very beneficial. So I tried to use this hemoperfusion for a prolonged period of time, but not with much benefit. During the hemoperfusion therapy, the patient's blood is directly contacted with the adsorbent, and then the targeted cytokines and other toxins are absorbed to the sorbent. So there is no hard and fast rules to start these therapies, but I designed myself that there are certain indications to start hemoadsorption at this particular level of research at the beginning of vital organ dysfunction. So if you have a patient with an AKIM stage 1 or at least 3 times elevated liver enzymes and requiring inotropic support, doubling of oxygen requirement in the last 24 to 36 hours, and then at the start of ARDS, so which is very difficult to define. So at the start of ARDS, at the doubling point of oxygen requirement, and then the inotropic support is going to increase, and then your liver enzymes are going beyond 3 times normal, and then the AKIM. So these are some of the points that where you can start this therapy. So there is an argument that are we starting these therapies very early? But if you start these therapies early, then you are not going to push the patients into frank organ dysfunctions. So what are the biomarker monitoring that is essential to start this therapy is, as I mentioned, that D dimers and IL-6. So, but the values that I mentioned are not hard and fast, and this is based purely on a single center experience. Comparing hemoperfusions with Cytosol and HA330, the surface area HA330 scores better, 40,000 and 50,000, and then the solutes removed are between 5 and 60, and here it is 10 and 70, almost similar. And the time of sessions, as they mentioned in Cytosol, is an extended session till 4 to 6 hours. But I did not see any benefit if you extend the session of Cytosol beyond 3 to 4 hours. And filter clotting, somehow, I don't know the reason for this, but I saw more filter clotting with Cytosol, and then the requirements of anticoagulants are more with Cytosol, whereas HA330 has got less chance of filter clotting. But the filter clotting depends on so many factors, including blood flows, including the levels of D dimers in those patients, and then the extent of rise in the inflammatory markers in those people. So I'm not very sure whether the Cytosol has got really more propensity to clot. Both are resin-based, of course. So the clinical monitoring is done only with the SOFA, mini SOFA, and Apache scores. So there's no other parameter that we always rely on: SOFA scoring, mini SOFA, and Apache. So if you cannot go the details of SOFA, then go only with mini SOFA scoring every 4 to 6 hours, and Apache once in a day. And then the lab, at least by 50% reduction of IL-6 and IL-2. But again, the problem that we faced is measuring these levels so often, and then we could not measure IL-2 in most of the patients. So we relied only upon IL-6, and we relied only pre-session and then the post-session IL-6 levels. So as I mentioned, that recommended standard of care as per WHO ICMR guidelines for severe disease, and the long-term consequences of these things, of these therapies, we're not very sure, because we are removing the good inflammatory cytokines as well. So whether these people are very much risk factors for infections and malignancy in a long term, I'm not sure, as mentioned in IL-6 blockers as well. So the advantages of hemoperfusion HA330, this is effective reduction of excessive cytokines, possible improvement in hemodynamics, and possible prevention of organ injury if you start very early, and then the shortens the ICU stay and hospital stay. Of course, we need large RCTs to confirm these points. So to conclude my talk, use of adsorption techniques for extracorporeal solute removal is a very effective and safe way of countering cytokine storm, unlike the IL-6 receptor blockers or IL blockers like sultiximab and tocilizumab. Wide range of cartridges with different efficacies and safety profiles are available, and what to choose and how to go about, and whether to go for hybrid therapies with CRRTs and ECMOs is case-to-case based. And head-to-head trials to compare these sorbent devices are needed. So which sorbent device scores better and which sorbent device is not good in certain situations. So these things need head-to-head trials. So in my own experience, in the months of April and May, all COVID RT-PCR positive patients, the number of patients we did extracorporeal therapy were 10, and number received HA330 with or without CRRTs around 5, and Cytosol I used in 5 patients. So the data was, it goes like this. I have not did a detailed statistical analysis on these patients, just an offhand experience. So the average duration of sessions that I took was around 3 to 3.5 hours. And the timing of initiation that I did is 2nd week of symptom onset with an IL-6 levels of more than 80 and with a vast hemodynamic support, at least one organ dysfunction, and not suitable to administer. So this important point is not suitable to administer tocilizumab, because the first option that was given to these patients were to use tocilizumab as per the ICMR guidelines. Then only we went ahead and offered the treatment of HA330. So those patients which are not suitable to administer tocilizumab only were taken for this particular sorbent dialysis, and no effect on the average length of stay in ICU. That I did not find any shortening of length of ICU stays, but definitely there is a reduced requirement of oxygen supports, and definitely there is a hemodynamic improvement. So the in terms of inotropic support, in terms of oxygen support, we got good results if we used HA330. Of course, I can tell that this is a mixed experience, that even with HA330, I don't know whether the timing of the initiation of HA330 was right enough in these patients or not. And this is my data, the IL-6, which we did end of first session and end of second session. There is definite drop in IL-6 levels compared to the baseline. And then the clinical picture also correlated very well with this IL-6. So 4 patients received heme adsorption and heme adsorption plus dialysis recovered from organ dysfunction, and 1 patient requiring heme adsorption plus CRRT succumbed to sepsis. Thank you so much. Thank you for the patient hearing.
Thank you, Doctor. Could you end your or stop your share screen? Okay, thank you. So thank you, Dr. Venugopal, for an interesting presentation. Now we're going to the session of Q&A. Thank you, Dr. Matteo, already answered some question in the Q&A bar. And now we still have one question here. It's why interleukin-6 level paradoxically increases after filtration. So I'm going to ask Dr. Venugopal this question. Do you have any comment on this question?
Can you repeat the question? Why IL-6 levels?
Paradoxically increase after the filtration.
Okay. In my patients, you mean to say in one of my patients?
This is asked from one audience. I think it's a general asked question.
Okay. So this is this usually happens if you measure very early after the session, and this usually happens because of the rebound increase in the levels. So this usually is bound to happen. And if you do the levels of these interleukins on the following day of your session, then you may see a fall. But if you measure these levels at the end of the session, you may have a rebound increase.
Okay, thank you so much. And also I have another question for Dr. Matteo. I see one article you published there is the comorbidity of the AKA in COVID-19 patients is increasing very high, so about 57%. So if we applied the cytokine removal in the early stage of the disease, should it will help on reducing the AKA events?
I think that it is a very smart question. Yeah, probably it could reduce the incidence and the severity of ATA, even because as the other organs, also kidneys suffers from the effects of cytokine storm, and also from the probably the direct involvement from viral spread. It would be very interesting to test it by performing a very early CRRT approach with those kind of patients, because it could, in my opinion, it could reduce the incidence and probably improve the mortality in these situations.
Okay, thank you. So thank you again, Dr. Matteo, for the interesting presentation, which explained some comorbidities of the COVID-19 patients, and also in sharing interesting case of using HA380 combined with CRRT or ECMO. And also thank you for Dr. Venugopal for sharing the experience, and also sharing the very interested presentation on the mechanism of the cytokine storm, and also introducing some of the cytokine removal devices. Also, finally, to sharing also sharing some of the experience of using HA330 cartridge. So also here we have another two questions. What is the dose and duration of the steroids received before starting hemopefiltration therapy? So is there any comment on this question, please? Dr. Yep.
Okay, we used, in my institution, we started using steroids very, very early, after 1 week from the spread of the COVID-19 pandemic. We didn't have any scientific statement, but it was quite clear that it was some kind of vasculitis, a small vessels vasculitis. So it was quite logical to think about steroids. We started with methylprednisolone 1 milligram per kilo for 10 days, and then we de-escalated it. So the standard dosage in my institution was that, and we are still using the same drug at the same dosage. What we saw in our patients is that this kind of therapy reduced the mortality. So it was also effective in reducing mortality of our patients.
Also, I had the last question. I'll ask for Dr. Venugopal. Do you think interleukin-6 levels less than 100 is really considered significant? And how many of these patients were already on the adequate steroids for more than 2 days?
Yeah, actually, I saw that question propped up on the screen. The thing is, in my experience, there is a very poor correlation between the magnitude of IL-6 and then the clinical picture. So a patient who has got a 23 or 25 interleukins will have a multi-organ dysfunction and a very high CRP and D-dimers. So as I mentioned, the things that I showed, that IL-6 more than 80 or the D dimers of more than 3 times normal. So these are not absolute values to start heme adsorption techniques. So you have to look at the constellation. That means your patient is losing an organ, and that means he has already gone into an organ dysfunction area, and then he has an elevated IL-6. So the IL-6 should not be taken as an isolated marker to start these therapies. So that is one. The second point is regarding the steroids, what Dr. Matteo has mentioned, that there are good number of studies to suggest that early initiation of steroid is very beneficial in terms of so many things. So as he mentioned, that I totally agree that methylprednisolone, we are still using methylprednisolone, but in the first wave of this pandemic, we used to give high doses of steroids, but we gone down on the steroid dosing, and then now we totally agree that the cumulative dose that we are giving is more or less the same, 1 milligram per kg, and then we are giving as a continuous infusion of these steroids for a period of 6 to 12 hours, so that the cytokine receptors get occupied with the steroids. So this makes sense. What do you say, Dr. Brivio?
Yeah, I completely agree with you. The continuous infusion is the best option to administrate the methylprednisolone. We try to do the same. During the pandemic, it was not that simple because we had a huge number of patients in Bergamo, as I think everywhere. But so we tried to administer it in the dividing it in the more doses, the more possible doses during the day. But now we are administering it in a continuous infusion fashion. Yeah, and probably this has an effect on the IL-6 and cytokines level that we measure now, because they are lower for sure, and they are probably better controlled. But there are still some patients that are different. They have an extremely high host response, which can be completely controlled even by the use of steroids. And those are the patients, I think, in my opinion, who benefits the more from the hemoadsorption techniques.
Okay, thank you, Dr. Matteo. Thank you, Dr. Venugopal.
Thank you.
And I'm going to announce the next webinar. It will be a seasonal webinar. It will be about the extracorporeal blood purification therapies and critical care. And next webinar, we will have two lectures. The first lecture will be presented by Professor Vladimir Cerny. He's from Czech Republic, and the other lecture will be presented by Professor Dun Ngoc San. He's from Vietnam. And also we will have a summarization and evaluation for the previous e-seminars by Professor Claudio Ronco and Professor Rinaldo Bellomo. Also, we'll have a discussion between the moderators and speakers. The next e-seminar will be in 25th of June. You are welcome to attend this webinar. It will be a big webinar, so you are welcome to attend this webinar. So thank you again, Dr. Matteo. Thank you again, Dr. Venugopal. I'm going to close.
Thank you very much.
You're welcome.
Thank you.
I'm going to close this webinar. So thank you for all attendees. See you again and goodbye.
Thanks. Thanks.
See you. Have a nice evening.
Thank you.
Thank you.
Have a good night.